So these are the three research priorities I would like to talk about, but I only have time to probably talk about two of them, so I'll do my best. We'll see. I want to talk about reducing disparities, not documenting disparities. We have documented disparities till the cows come home. We can all agree that there are huge treatment disparities and comorbidity disparities, et cetera. We've got to start treating the disparities. Developing and testing treatment adaptations, and I'll tell you why in just a minute. And then I think everybody's mentioned examining key factors of implementation and sustainability, so that's probably one I'll go a little bit light on. I'm going to focus on the problem of pain in low socioeconomic status populations because for the past 15 years that's what I've studied and targeted my treatment efforts on. And one of the reasons I've done it that way is because this is a high-impact pain population. They lack access to healthcare resources, they have higher rates of pain and disability, and they have higher rates of all kinds of comorbidities. So they do have high-impact pain, and they have more of it, and they get less treatment for it. And most of our research, or much of our RCT research, has really focused on or utilized middle-class patients with high health literacy. They're more available. They've been said to be more recruitable. They've been said to be more retainable. They've been said to be more motivated. And because of those reasons, often people with multiple disadvantages, like income disadvantages, for example, have either been excluded outright or have been excluded for other reasons like low literacy. And the conclusions that we make with our RCTs with middle-income patients may not really generalize, and I will give you a real-life example of that in a minute. So we need treatment research targeted toward disadvantaged individuals. And I think Rob Edwards talked about catastrophizing as not only, well, he wasn't talking about it as a key mechanism of change, or maybe was, but he said it's a modifiable risk factor. And I wanted to make a distinction between modifiable and perhaps not modifiable risk factors, and I think it's particularly important for the population that I target and have worked with for a long time. Catastrophizing is a modifiable risk factor, and we've got lots of good treatments to work with that. Income is typically not considered a modifiable risk factor, and so I think we have a tendency to push it over here and say, well, we can't do anything about that. I would argue that that's where we can modify our treatments. So we do the modifying rather than modifying the participant. We modify for the participant. And so what I've focused my efforts on is adapting our cognitive behavioral treatments, self-management, pain management, treatments to help patients who might not necessarily get the 3-column forms for cognitive therapy, and they might not do a whole lot of reading and writing, but they can get the treatment and they can benefit the treatment if we will adapt, and we will adapt for their literacy levels. And this little thing up here is just a copy of the patient workbook that we used over the past quite a few years in a few RCTs, thank you NIH, thank you PCORI, to compare efficacy of literacy-adapted treatments with targeted low-income patient populations. And we got good outcome results. You can't hardly see that, but we recently published the main outcomes paper in Annals of Internal Medicine. Now, I mentioned to you that people with different disparities may not have the same effects. And we just finished the heterogeneity of treatment outcome analyses. And even though pain education, literacy adapted, and cognitive behavioral therapy, literacy adapted, both had significant effects over and above medical treatment as usual. What was interesting, and we were very surprised, but now I think we understand why. What was interesting is those with the lowest literacy levels and the lowest cognitive function did the best in our cognitive behavioral therapy, adapted treatment. We think the reason is if you have high sort of literacy levels, you can take education and run with it. If you have low literacy levels and multiple disadvantages, you need the structure, you need the audio aids, and you need the patient materials that aren't reliant on the written word so much. And I will stop there.